Obviously, in terms of our standard of care, we still use CT scans and tumor markers to detect early recurrence after a surgical resection for BTC. However, as you know, the ctDNA is an evolving field where it is not being used in colon cancer and it is being explored in other diseases as well. So our data set was a more of a retrospective analysis of a couple institutions that looked at ctDNA to look at if it could detect early reoccurrence in patients with BTC. And what we found is that based on our small study of about 50 patients, the ctDNA really outperformed both imaging and traditional tumor marker. So compared to imaging, for example, the ctDNA detected recurrence earlier than imaging in about 70% of the time. The ctDNA provided some molecular evidence that the evidence of recurrence even when imaging was all still negative. And compared to CA19-9, ctDNA was more significantly more predictive of recurrence than CA19-9. And even among the discordant cases, where about 80% of the patients were ctDNA positive, but CA19 negative, the patients relapse. On the other hand, only 13% of the patients were CA19 positive, but ctDNA negative patient relapse. And furthermore, the ctDNA was really the only biomarker associated with worse relapse-free free survival compared to CA19-9 based on our study. So this was a retrospective multi-institutional study where we looked at about 56 patients, inpatient with resected stage 1 to 3 BTC patients. And this evolved from anywhere from September 2019 to April of 2023. And in those 56 patients that we included, many of them had ctDNA drawn in the MRD window, which was defined as anywhere from 2 to 12 weeks post-surgery, and in the surveillance window as well, which is defined as after adjuvant therapy or 6 weeks post-surgery. And in this study, we used the personalized tumor-informed ctDNA assay, Signatera, with serial plasma sampling. And in this study, we were trying to look at key outcomes, such as the prognostic value, to see if ctDNA helps with early detection, and also looking at some of the sensitivity, specificity, positive predictive value, negative predictive value, and try to correlate to see if it is really better than CA19-9. I just want to say that even though our data shows some promises, it is really a limited data in BTC. This is one of the first paper that is published in this area with only 50 some patients, right? So obviously you have to take it with caveats, right? And this is a real world study, right? And it is not a prospective randomized study, and really lacking standardized protocol for ctDNA collection, right? So making it really unclear exactly when testing is most impactful, right? Also, obviously we have to balance the cost and the logistic with the testing as well, since it is not really considered a standard of care. Last but not least, I think two things is that access and cost is one thing, right? Because in some places this platform is not readily available. And I think the last question is, how do we incorporate this in ctDNA positivity into our treatment plan? As I mentioned before, it is very prognostic, but the ultimate question is it predictive, and can we do something about the results? Yeah, I think only thing that we found that was the correlate was that any ctDNA positive post-surgery was bad, was associated with worse RFS. I think that's one thing that we found out for sure. And we also found out that persistent or recurrent ctDNA positivity over time strongly correlated with relapse. But obviously, other than that, there were no other specific mutation pattern that was linked to prognosis or any kind of other factor that we could find in our study. Yes, I think that's the ultimate question. As I mentioned before, similar to other diseases, such as colon cancer or other GI tumors, the ctDNA is a very good prognostic marker, meaning that if you're ctDNA positive, overall outcome will be worse compared to patients who are ctDNA negative. I think ultimate question, as you ask, is that how does it influence my adjuvant decision, right? Does it influence anything? Well, two things it may play a role. We know that the MRD positive patients after surgery are likely at very high risk of recurrence. Okay. So in that case, we could justify maybe doing surveillance a lot sooner than later. Okay. Second thing is that, maybe in those patients, there could be some trials available for those patients to enroll. Okay. But clearly at this time, it is too premature to say that we're going to de-escalate or escalate treatment based on the MRD finding. However, there are example cases where the MRD positivity patients led to different type of treatments, such as immunotherapy, if the patients were MSI high, telling us that in those certain cases that you could use a targeted therapy or immunotherapy to clear ctDNA, potentially improving the outcome. But once again, those are only case-based scenarios, and we need a larger series to prove that. And also the MRD negative patients, we know that false negative can be as high as 20% in some cases. So therefore, I think if you have MRD negative patients, those are good. But once again, I will not de-escalate any treatment just based on the MRD status. So, so in conclusion, obviously, based on the finding that we have, it is a very prognostic, but it is not predictive yet. So therefore, I think the further, we need a larger sample size that's probably randomized to tell us that it's not only prognostic, but also predictive as well. In our study, the distribution of BTC subtypes, such as intrahepatic, extrahepatic, gallbladder, ampullary, were pretty even. And really, the recurrence detection and prognostic value were really observed across all subtypes. Even though, once again, the sample size were very small to have any kind of a formal subtype specific analysis. And there was no clear evidence from our series that the ctDNA performs better in one subtype over another. Yeah, so I think right now we are looking at a larger series right now. So our study was mostly two institution study, but we're looking at multi-institutional, over 10 institution studies as well, looking at the same question about the prognostic value of ctDNA and of the ctDNA in BTC patients. So that data will hopefully be presented at ASCO coming up this year. But once again, ultimate question is, what do you do with the results if it's positive? And I think this is where the future study will hopefully answer that. Now, I think something that unique about the BTC is that about 40 to 50% of these patients have an actual mutation that could occur, such as patient with FGFR fusion, such as IDH1 mutation, such as patient with MSI high. The example that I gave of my patient that were actually ctDNA positive during the MRD window on adjuvant and capecitabine, were able to receive immunotherapy because that patient was MSI high. And by giving the immunotherapy in those patients, I was able to clear the ctDNA positivity. And those patients, actually, that patient actually died of some other reasons than the disease itself. So I think that's the future, but obviously we need more data to prove that.